Hello, and welcome to part 2 of the lecture on chapter 16, musculoskeletal system. We had just finished off with joint injuries. In general, we were talking about damage to some of the structures in the joints. And now we're going to look at one particular joint, and that is the knee joint. I realize now that the little screen of my head may be covering part of this diagram, so sorry for that. Let's just talk about a little bit about the structures that reinforce the knee. There's a four-headed muscle called the quadriceps here in the upper thigh, here in the thigh. And these four heads of muscle converge onto this one tendon, the quadriceps tendon. It attaches to the bone called the patella. Then there's a section of this dense connective tissue that continues on to the tibia. That's the patellar ligament. So quadriceps tendon and patellar ligament. And then on the sides, the knee is reinforced by these so-called collateral ligaments, meaning they're on the outside. They're on the sides of the knee joint, medial and lateral collateral ligaments. Medial, of course, is on the tibia side and lateral is on the fibula side. Then let's take a look at the inside of the knee. There are some other structures that help stabilize this. There are two ligaments inside the knee that cross from the distal end of the femur to the proximal end of the tibia. The one in front is called the anterior cruciate ligament, or ACL. You may have heard of this one before. And then there's one crossing in the back, posterior cruciate ligament. In addition to those ligaments, there's also these pads of cartilage. These are called menisci. Singular is meniscus. And they provide extra cushioning. This is a joint that takes a lot of pounding. And as I've already mentioned, the collateral ligaments on either side. And any of those structures can get damaged. This is another diagram. It's not from our textbook, but it had a lot more detail. The quadriceps tendon has been cut, and then the whole patella has been reflected away from the knee. So you can see the internal structures of the knee, the cruciate ligaments, and the menisci. Let's take a look at damage that can happen. We can have sprains, as in any joint, resulting in varying degrees of ligament tears, of course. So, grade 1, grade 2, grade 3. The medial collateral ligament is one that is frequently affected. And the way this gets broken is by a blow from the outside. So in football, for example, the foot is planted and then somebody gets tackled from the side, and that pushes towards the medial. So from the lateral side to the medial side, and that can lead to a rupturing of this ligament. The ACL famously gives way 10 times more commonly than the PCL, than the posterior cruciate ligament does. The way to assess this is there's movement in the knee that shouldn't be there. I mean, the patient will report pain, of course, but if the knee can hinge open on the medial aspect, it's not supposed to, and if you can pull forward on the tibia, that indicates that the ACL has ruptured. Let's see, damage to the meniscus also happens. It generally happens when the knee is slightly flexed, and it's bearing weight, that is, the person is standing up, and there's twisting motion, and that crushes the meniscus. Just think about if you've ever tried to kill a bug with your shoe. You step and twist, that's going to be the most damaging force that you can do. And that is what is happening inside somebody's knee. The three cardinal signs of meniscus injury, of course, is the tenderness, the joint line, there's swelling, and the knee feels like it's locking in position. To confirm the diagnosis, this has to be done either with an MRI imaging or with actually going in and taking a look with arthroscopy. Arthroscopy is also frequently required to pull out any broken pieces of cartilage. All right, that was fast and dirty on the knee. Now we're moving on to the back. It's extremely common for people to report back pain, and it can have all manner of causes, many of them just due to muscular overexertion. There can be arthritis, swelling of the joints, but we'll cover that later. Here, we're just going to talk about herniated disc disease. Let me remind you of the anatomy of the vertebral column. We have vertebrae that are stacked on top of each other. They articulate with the other vertebrae above and below them in two ways. In the front, they articulate, the whole body is just sitting on top of the body of the other vertebra. There's not a lot of space here. You have a cartilaginous pad. It allows for some wiggling, but these bones are, attached to this cartilaginous pad, which is attached to the next vertebra. Those are the so-called intervertebral discs. Then in the back, there are processes that stick out. Let's see, there's processes that stick out from, oh my gosh, how am I going to do this? From each other. And they articulate with each other in the back. The bodies are on top of each other. And then these, you can get a little bit more wiggle room, the synovial joints there. We'll come back to those later also. And there's a spinal cord running through this space here. That spinal cord is part of the central nervous system, and it gives rise to the spinal nerves that are part of the peripheral nervous system. The spinal nerves have to come out in between the vertebrae. These are called the intervertebral foramen. All right, so if the intervertebral disc gets squished in such a way that it's pokes out a little bit. If it pokes out to the front, I mean, it's still a herniation, but it's not pressing on anything. If it bulges out to the back or to the side, there's a chance that it's going to press on the spinal nerves. That's the big problem with the herniated discs. So what we end up with is the disc, you're in blue, sticking out somewhere. And depending on where it's sticking out, the sticking out part is shown in red. Depending on where it's sticking out, it's going to impact what nerves it's pressing on. So we can end up with a compression of the spinal cord itself, part of the central nervous system, but then it can be compressing the nerves that are coming off. What part of the nerve is being compressed determines whether the patient experiences pain. There's sensory neurons that are being affected, or just motor neurons. Let me show you what I'm talking about. It's a cross section of the spinal cord. We barely talked about the spinal cord last week, but if we take a cross section through the spinal cord, what you can see is that there's organization in the spinal cord. Remember how we talked about there's sensory information coming in towards the central nervous system and then motor information coming out? Afferent and efferent signals. Okay, so there's that kind of segregation of cells in the spinal cord. And so we have incoming signals. They come in through the dorsal root, through the back door. Information is coming in. And then outgoing information is through the front door, the ventral roots. So depending on which part of this is getting squished, that determines whether the person experiences pain or motor involvement, weakness of the muscles that are being innervated by that nerve. Of course, it can be both if both bits are being affected. All right, now we're switching gears again. We're going on to repetitive stress injuries. The one example we're going to talk about is carpal tunnel syndrome, but it can happen in other joints. So involves muscles, nerves, tendons. It's often occupation related, something that a human being is going to do for hours and hours and hours. And typically, the only things we do for hours and hours and hours are things that we do for money. And so often it is jobs in factories, canning, typing. So it's often in the arm. That's the problem. And holding, here we describe it as awkward positions. Just something that is continuously irritating. It's stimulating a particular muscle or set of muscles and not challenging another set of muscles for balance. There's an impingement on the blood supply, the nerves get damaged, the tendons get irritated. Sometimes just improving the ergonomics. That's what those wrist pads are about, to help put the hands in a better position for typing. Some people like the split keyboard. And there can be improvements to factory setups so that people don't have to do exactly the same movement, or can do it in a way that's not damaging to their joints. So carpal tunnel, as I mentioned, the tunnel that's being referred to is this retinaculum. There's a strip of connective tissue that helps keep all the tendons, nerves, and blood vessels kind of in place. And you get inflammation going through this tunnel. Sensory findings, there's pain and tingling, numbness sometimes in the hand, and then the motor finding, there's weakness and abduction. That's moving the thumb out. And moving on, some things to consider with musculoskeletal system and kids. Fractures of bones are common with kids. Not as common as you would think, given the number of times that they fall, but kids fall a lot. And so we do see fractures, bending, green stick fractures. That is the fracture that doesn't go all the way through, because the periosteum is thick, and there's more flexibility. The bones are not completely mineralized yet, and so they provide a certain amount of flexibility. They have the collagen in place. They just haven't completely mineralized yet. The good news is that healing happens faster in kids than it does in adults. So what would take 6 to 8 weeks in an adult might take 4 to 6 weeks in a kid. Right, genetic disorders, it's not that people outgrow the genetic disorders, it's just that they're typically diagnosed in childhood because they have these severe consequences. So one genetic disorder that we've already talked about in this class is muscular dystrophy. This is an X-linked recessive. That means the gene that codes for the protein involved, that gene occurs on the X chromosome. And so for an individual to show the disorder, males only need to inherit 1 defective copy. Females would need to inherit 2 defective copies of this gene. So in any case, the person who has this disorder, they have a gene that is defective for a protein called dystrophin. It's a protein that helps to anchor the actin and the myosin in place in a muscle cell. So I'm just quickly remind you, actin and myosin have to hold on to each other. We've got the tropomyosin wrapped around the myosin. The troponin is what binds the calcium ions to roll the thing out of the way, and that allows the actin and myosin to hold on to each other. If that is not anchored to the cell membrane, to the sarcolemma, by this protein dystrophin, the muscle can't work, it can't contract effectively. The version of muscular dystrophy that I think we spoke about in class was Duchenne's muscular dystrophy. This is the more severe version of it, and can lead to symptoms earlier and can lead to death earlier. The folks who were diagnosed with Duchenne's muscular dystrophy are making it to adulthood now. This used to be progression to death in childhood. And there's other versions of this. There's a Becker muscular dystrophy. In that case, the dystrophin is abnormal, but still somewhat functional. And so, as you can imagine, the symptoms are not as severe as with Duchenne's muscular dystrophy. A second genetic disorder I'm going to mention just in passing. The first one related to the muscle tissue. The second one relates to the bone tissue. So osteogenesis imperfecta, this is also known as brittle bone disease. It's an autosomal dominant, so it will affect males and females equally frequently. The protein, the gene that, let me rephrase that. The mutation is in a gene that codes for collagen. Collagen is an important part of the extracellular matrix in the bone. And this abnormal collagen results in these really brittle bones. And so kids, babies, have bones broken. And initially it may appear like a case of child abuse, but it's not. It's just regular handling of the baby is resulting in broken bones. Nowadays, we have a genetic test for this disorder. There is no treatment for this really, except now, since we know what the problem is, we know to focus energy on helping the child to develop bone strength by, guess what, physical activity. So with physical therapy, improving the strength of the muscle helps to stabilize the skeleton, but also helps the body to get the signal that this bone needs to be mineralized, needs to be strengthened. Okay, and now we are shifting gears to older patients. Gerontological consideration for musculoskeletal. Aging is associated with loss of bone mass. The osteoporosis is where the bone appear to have pores. Now, this is normal spongy bone. You know, it has these big openings, but that they're supposed to be there. These, you know, weird towers of bone. But then if you look at osteoporotic bone, you can see that they have more pores. This is because the osteoclasts are really active and the osteoblasts are less active. So there's not this balance. So the osteoclasts are doing what they're supposed to do, which is break down bone, but they're not being counteracted by osteoblasts putting down more matrix. It turns out that bone loss accelerates as the steroid hormones decrease. So a loss of estrogen, loss of testosterone. It seems to be, the problem seems to be that in the presence of estrogen and testosterone, the osteoclasts do a little bit of breakdown and then they die. And as estrogen and testosterone levels go down, the osteoclasts, you know, break down a little bit of bone, and then they break down a little bit more bone. So in females, there's a faster acceleration of bone loss after menopause because of the big drop off in estrogen levels. In males, there's also a drop off in testosterone with age, but it's not as precipitous as it is for females. How to assess this? We do it through bone, a measurement called bone mineral density. And it's done with dual energy X-ray I can't say it, DEXA scan. And the reason it has to be done that way is because just checking the blood level of calcium is not necessarily informative for bone density, because remember, calcium's required for heart muscle contraction. It's required for nerve signaling. So the body is very good at maintaining enough calcium in the blood and will sacrifice the bone in the interest of keeping enough calcium in the blood to do those other jobs. And so that's why the blood level of calcium isn't necessarily informative. Now, some amount of bone loss can be counteracted by enhanced physical activity. The more weight-bearing exercise the person does, the more the body gets the signal, hey, osteoblasts, you need to do your thing. You need to put down more minerals in the bones. Okay, now let's take a look at what happens with muscle mass. We also see a loss of muscle mass with aging. This is referred to as sarcopenia. Sarco is muscle and penia is poverty. So this is one component of the clinical frailty indexes. There's lots of factors that contribute to sarcopenia. Loss of different parts of the muscles, muscle cells, loss of innervation. Here's another really important point. Some amount of this sarcopenia may be counteracted with enhanced physical activity. So at the very time that our patients are losing muscle mass, losing bone density, they may not feel like they're the strongest they've ever been. That's when they need the physical activity, because it's going to help counteract some of this, loss that we associate with aging. So empower your patients. They can help prevent some of these problems. All right, now let's take a look at joint disorders that are often associated with age. These are the arthritis. So itis, inflammation, arthro refers to the joints. The most common one is osteoarthritis, but we'll mention a couple of others. Gouty arthritis, also known as gout, and rheumatoid arthritis. So osteoarthritis, what's happening here is we're losing articular cartilage. We're losing that other tissue that covers the ends of the bones where they articulate. And so there's swelling. There's these bony spurs that can start to form when the bones are hitting other bones instead of just, the cartilage gently tapping in, got bone on bone, and the bone responds by starting to grow more bone. It's not beautiful. The obesity is a risk factor because of the extra stress on the bones. Just carrying around this extra weight that we carry is harder on our joints. Also, if there's been a prior injury to that joint, that's a risk factor for developing arthritis in that joint. Lifestyle recommendations. Again, this is, the patients are experiencing discomfort and may not want to use these joints. And yet, by strengthening the muscles around those joints, it helps to stabilize the joint and actually may help control some of the pain that the patients are feeling. Also, weight loss will help to decrease the stress on the joints. And that's why that's being recommended. It's not to beat up the patients, but again, to empower the patients, for them to know that there is something that can be done about some of this discomfort. Just a flow chart, some pretty colors, some of the same stuff I already talked about. All right, gouty arthritis or gout. This can happen in younger patients as well. It's an imbalance of uric acid production and uric acid excretion through the kidneys. Uric acid is normal. We have it in our bodies. It's a natural waste product from metabolizing purines. Purines, you may remember, are the nucleotides that have two ring structures. Let me see, it's the adenine and guanine. Yeah, adenine and guanine. In DNA, it's also the A of ATP. So those are the purines. So clearly all of us have purines. Not everybody develops gout, however. What we see in somebody with gout is, of course, elevated level of uric acid, but you'll see that sometimes in other patients that don't have gout. But so along with the elevated levels of uric acid, we often associate dehydration with this. Low temperature, curiously, which may actually help explain why one of the first places that people experience pain from gout is in the big toe. It's about as far away as you can get from the rest of the body, and is, maybe a little bit cooler than the rest of the body, and may allow these crystals to form. Once the crystals start to form, it's easier for more uric acid to crystallize on those crystals. The joints get lots and lots of inflammation and swelling, incredible amounts of pain. And all, remember blood vessels vasodilate, more blood to the area. So we get redness in the area because we can see the hemoglobin through the skin. And then the pain, the release of the prostaglandins that are tickling the pain receptors, just awful. Samples of synovial fluid show that there are crystals in there. And it's also possible for the crystals to be deposited in the skin. These are visible as tophi, especially around the ears. Places where we have cartilage allows the tophi, the crystals to be deposited. One suggestion is to increase water intake, help to avoid the dehydration. So it helps to dilute the uric acid and helps to flush it out, which may help avoid development of uric acid kidney stones, which sometimes happens with patients with gout. One more kind of arthritis, rheumatoid arthritis. This one is an inflammatory joint disease, so it's involving the immune system. Rheumatoid arthritis may occur in younger patients as well. It's not as common, but it can happen. In younger patients, it tends to attack the larger joints. So it's an autoimmune disorder, leads to chronic inflammation of the joints, which of course is going to lead to pain. And it leads to this overactivity of the osteoclasts, so breaking down the bone tissue, and that leads to the changing shape of the bones. The deformities that we see in the hands and the feet. It's diagnosed, of course, with local symptoms, pain, inflammation, but also symptoms of systemic inflammation, so blood markers of inflammation. And then another kind of inflammatory joint disease. This is spondyloarthritis. The most common form is ankylosing spondylitis. Ankylosing means fusing. If you're fans of dinosaurs, ankylosaur is the fused lizard. Yeah. All right, so let me remind you about the skeleton. You saw this diagram before. Do you see the part that's shown in kind of a darker peach colored? This is the so-called axial skeleton. It's the kind of the central part of the body, the head, the vertebral column, the ribs. I think of this as the part of the skeleton we have in common with snakes. So that's axial skeleton. The rest of the skeleton, the stuff that helps to anchor the arms and legs, that's all appendicular skeleton. So this primarily affects the axial skeleton. And we've already talked about the vertebrae and how they articulate here at the body, but they also articulate at these other facets. Here, these are synovial joints. And so there should be lots and lots of movement. And instead we get all this inflammation and then fusing here. That's where the ankylosing comes from. You're fusing the bone. So the patient is completely losing mobility in these parts of the bone, or parts of the vertebral column, which leads to a lot of discomfort, of course. Inflammation, bony overgrowth, the fusion of the bones. Oh, this can also affect, remember I said axial skeleton is the central part. It also affects here where the axial skeleton joins the appendicular skeleton. It's known as the sacroiliac joint. This is the sacrum and this is the ilium. So the SI joint is also affected. And this again is an inflammatory joint disease. So there would be markers of inflammation for this one too. And that is the end of musculoskeletal system. Have a great week.